Secretary Becerra, I just want to tell you something at the beginning. These folks from Rutland don't usually behave so politely.
I told them to please behave.
And this Mayor Allaire, thank you. The Mayor, Secretary Becerra, thank you.
It's a pleasure to meet you, sir. Thank you.
You think I'm kidding. And they got dressed up. You know, I don't I am so happy to be here. I just want to start by saying that. You know, this is my first official day, not my first official day, but my first official working day as the new United States Senator from Vermont. And I always want to acknowledge Patrick Leahy, as we all do. But my first day is right here in downtown Rutland, Vermont. And, it's really wonderful of Xavier and I go back, when I first went to Congress 16 years ago, he was one of the first people to call me and not only welcome me, but then try to help me get off to a very, very, very fast start. And we worked together for several years in Congress, and he was in leadership all those years until he was tapped to be Attorney General in California. And he did a brilliant job there until he got a call to see if he might be willing to serve in probably one of the hardest jobs in government, and that is Secretary of Health and Human Services. And Xavier is here, and I'm very grateful to you to just show that support. I just also want to say something about this extraordinary hospital and the people here. This is a rugged working person's community. And the hallmark of Rutland is you stick together and you help each other. And this institution has been absolutely essential as a driver of the economy, but also, more importantly, helping folks and families and children from everything from a cold to serious cancer. And I just want to acknowledge that. And one of the things that they've been very involved in, of course, is dealing with the opioid crisis. And Secretary, you know what a challenge that has been. So just that's by way of introduction. I'm grateful to everybody here and the work you've done, because I know how much effort you've put into the well-being of Rutland. And I really am grateful to the Secretary for coming up from Washington to be with us. And now I'll turn it over to Judy. And thank you for hosting us.
Sure. Glad you're here. So I'll just start out with a few opening remarks. So it is my distinct pleasure to welcome Senator Peter Welch and the United States Secretary of Health and Human Services, Xavier Becerra, to Rutland Regional Medical Center. Thank you for taking the time to be with us today.
Thank you.
Rutland Regional has been at the forefront of addressing substance use since it opened our area's only methadone clinic at the Westridge Center about a decade ago. Today, our clinic serves over 400 patients each day, providing treatments that allow them to manage their disorder and lead productive lives in our community. While we do not have a waiting list now, volume is increasing. This increase is in direct correlation to increases that we see in crime and overdose in our community. Although we're proud of the access that we have for outpatient treatment, unfortunately, our community lacks sufficient inpatient residential treatment. Insufficient access to residential treatment is a lack of both limited residential treatment beds and the lack of funding to support patient placement. Even as Rutland Regional and Vermont have embraced the transition to a value-based care system, opioid addiction continues to rise. This rise adds additional challenges to the sustainability of hospitals, which are already facing severe workforce and inflationary pressures. Meeting these challenges requires increased investment in integrated solutions built around care models that coordinate care regardless of where you receive services. To address the issues patients face and to promote recovery, investments in integrated social supports such as transportation, housing, food, and workforce skills are all required. To truly transition to value-based care, innovative care delivery practices need to be expanded to include telehealth services and digital medication delivery capabilities. To address the issues patients face and promote recovery, investments in integrated support, to truly transition to a value-based care delivery practices need to be expanded to include telehealth services and digital medication delivery capabilities. I've said that twice, so it's really important. Treatment delays need to be addressed through modernized regulations that support efficient care delivery and appropriate sharing of vital medical record information. As we know, these programs are not self-supporting, but are critical to the communities that we support. We fund these programs from revenue generated from other areas in our hospital. For Rutland Regional, the 340B program contributes significantly to our ability to provide these services. Without revenue like this, we would be challenged to continue to provide the services. As substance abuse disorder continues to grow, we must expand access to treatment and adopt new payment mechanisms to ensure care is not compromised. We are ready and willing to partner with state and federal agencies and regulatory systems to continue to create access to high-quality care for our community. Now, to offer firsthand knowledge of the impacts of substance abuse disorder to the greater Rutland community, I'd like to introduce three colleagues. Dr. Allison Davis, a board-certified emergency physician and the medical director of our emergency department. Dr. Sahid Ahmed, a board-certified psychiatrist, the medical director of the West Ridge Center, and an expert in addiction medicine. And lastly, Rutland City Chief of Police, Brian Kilcullen, who is also an advisory committee member for Project Vision, a community collaborative dedicated to addressing broad social and public health issues that accompany substance abuse use disorders.
And I was thinking we'd have Secretary Becerra just make a few welcoming remarks. Secretary, thank you so much for being here. Xavier Becerra, Secretary of Health and Human Services.
So I want to thank Senator Welch for letting me be here. I'm thrilled to get to work with the senator. I've had nothing but a phenomenal friendship with Peter Welch as a member of Congress and now, of course, as a member of the Senate, and very much looking forward, like you are, to his leadership in Congress. We need him. Ms. Fox, to you and the team at Rutland Regional Medical Center, thank you for everything you're doing. Look forward to hearing from folks. Chief, having served as the Attorney General in California, I'm very much looking forward to what you have to say, because I know in law enforcement, this is critical for law enforcement, because I know that you don't have enough personnel to go around on the streets to take care of the real issues of crime, and you do everything you can to get your men and women who were trained at the academy to do something other than being mental health counselors and substance use treatment officers and so forth. So I know that this is big for the police force all the time. And I want to make sure I mention Everett Hanford, who is my boss here regionally. Everett handles all of HHS's affairs here in Vermont and in several other states, and he is our point person. And so anything that you need to convey to HHS, if you get it to Mr. Hanford, it will be coming to us, and I hope that you will come to us often, because on this issue of behavioral health, on substance use disorder, we got work to do. And I say that having left as the Attorney General, trying to negotiate settlements with a number of the stakeholders who had a lot to do with making this into the crisis it became. We've now secured tens of billions of dollars from some of these manufacturers and distributors. Still doesn't make up for what the communities are paying. I mean, you can't make up for a lost life, right? And we have lots of work to do, but we want to help. And President Biden has given us more tools, more resources, more authorities, working with Senator Welch and his colleagues to be able to do some of this stuff. So we're very much looking forward to it. So I thank you for inviting.
Allison?
Okay. Good afternoon. I'm Allison Davis. I'm the medical director of the emergency department here in Rutland. I've been at the hospital for 11 years, and I've been the medical director since last spring. So thank you for the opportunity to speak with everyone today. I wanted to share a few of the trends in the emergency department that we've seen over the past 3 years of the pandemic and the impact of substance use disorder on healthcare from the ED's perspective. So first, we're seeing a rise in opiate overdoses in patients who don't realize that they're using drugs that have been contaminated with fentanyl. So, for example, we've seen deaths in patients who had bought cocaine but died of an opiate overdose because of the cross-contamination. The addition of fentanyl to heroin also means that it requires greater doses of Narcan to be able to revive patients, and oftentimes patients are requiring IV infusions of Narcan over an extended period of time, which is not something that we saw 10 years ago. The other contaminant of great concern is xylazine. And I imagine that many of you saw the article in the New York Times over the weekend about the impact of the drug in Philadelphia. Trank dope is becoming omnipresent here in Rutland as well. And the problem really is twofold. So the tranquilizer can't be reversed with Narcan, and it precipitates a more severe withdrawal. We haven't yet seen the type of wounds that were described in the New York Times article, but I imagine that we are going to. Switching gears slightly, we're also seeing the impact of opiate use disorder and the growth of that issue on children in our community. We're seeing more children coming in from schools into the emergency department with behavioral issues, having experienced both physical and emotional trauma in their homes related to substance use disorder. Our schools are struggling to support these children, and they're increasingly relying on both the police and the emergency department to serve as safety valves when behaviors escalate. Unfortunately, we're also treating children as young as 2 years old who have overdosed on their parents' medications, on their parents' heroin, and have been brought into the emergency department after EMS has revived them with Narcan. This kind of case means a long night in the emergency department, not only for the child, the patient involved, but also for the other children in the family who then are brought into the emergency department for evaluation. It's a long night for our social workers, for the Department of Children and Families, and for the police. And then finally, I wanted to touch on the impact of opiate use disorder on overall hospital and emergency department capacity. For many patients, initiation of outpatient management, particularly with Suboxone, is simply not enough in the acute setting in the context of fentanyl and xylazine. Those additions to heroin have made acute withdrawal much more acute and more difficult to treat. I think Dr. Ahmed is going to talk about that a little bit as well. Patients are afraid of experiencing unmanaged symptoms. So, as Judy mentioned, our community really does need more capacity in terms of residential treatment programs. If patients aren't able to access the treatment that they're looking for when they're ready for that treatment, they end up bouncing back, and often they come back with more severe medical conditions. They're returning with infections of their heart valves, infections of their spinal cords, and even then, they'll sign out of the emergency department and avoid treatment because they're afraid of the withdrawal. Separately, but also related, and this is a national trend, but something that we're experiencing in Vermont, and that's that patients on Suboxone and methadone often are unable to get beds in long-term nursing facilities. And that leads to unnecessary utilization of hospital beds by patients who no longer need that level of care. That has a ripple effect and ends up causing crowding and boarding in the emergency departments. And again, like I said, that's a national trend, but it's a local problem as well, and it's something that we felt in the emergency department here. So steps that our emergency department has taken to try to address opiate use disorder have focused both on harm reduction and on bridging to treatment. So we've initiated a rapid access to medication program with Suboxone and RED. We have fentanyl test strips. We have Narcan available in the emergency department free of charge for anyone who would like to take some home. And we also have an amazing partnership with a local peer recovery group here called Turning Point. They provide peer counseling and peer support to patients in the emergency department for anybody who comes in with an issue related to substance use disorder. They're on call 24/7, and they do amazing work. I wanted to end my comments with one suggestion, one piece of policy that I think could make a difference in terms of our ability to treat patients in the emergency department. And that's the privacy surrounding methadone dosing. So currently, those records are protected by federal statute. It can make treating patients who are on methadone very challenging because we're unable to see accurate information in terms of their dosing, their prescription amounts, when they last were treated, and we end up either being unable to provide them with the appropriate dose or, worst case scenario, doing harm by treating them with an inaccurate dose. And the workarounds for this are pretty clunky. They're time-consuming. And I think that if methadone treatment records were available in the EMR more easily accessible to pharmacists and providers, we would be able to support our patients on methadone better. So thank you for the time. Thank you for listening. I really appreciate it.
Thank you.
Yeah, thank you so much. Yeah, I appreciate it. Thanks for the opportunity. Welcome to Rutland, Vermont. Thank you. First of all, I would like to start by thanking you and Senator and the current administration for omnibus bill. It's going to impact and affect a lot of stuff what we do day-to-day basis in the form of Mainstream Addiction Match Act, which I see like I actually printed like 6 pages and several things we've been talking about, several things we've been looking for. There's going to be implemented through this bill, which is going to be amazing. So to start, Dr. Davis mentioned a lot of issues and problems we are facing here on a day-to-day basis when we practice psychiatry or medicine. I'll be trying to be very focused on some of the solutions that I might propose that might be helpful for us when we provide as services to the community or as a Vermont as a state. One of the programs I would like to talk about, first I would like to thank the Senator for securing federal funding for Wheels and Waves program, which is an innovative program for those rural areas where it's extremely difficult to reach out to the folks to get them methadone. It's a very innovative program. I don't know how much you're familiar with this program, but it is patients are given a lock box, which is a pre-programmed by the hub, by the methadone clinic, where we load this device for 30 doses, take home, and we give them, and it's being, when they go with this device, we actually monitoring them through telehealth. Now, this is really useful and critical for first 90 days. That's the peak or the critical time when people drop off. They drop out, and when they go through this period, which is critical for any drug user, especially opioid addict, by that time they earn take home, and that's the time when they're much more likely to stable, and we take away this device back. So the results are phenomenal. The pilot study was done in Burlington, in the area premises of Burlington. More than 95% retain in the treatment a year later compared to 50 or less than 50% in the other clinics in the area, which is amazing, 95. So that's now the request is, obviously we would come with a request from HHS and SAMHSA. Well, this is really.
You should be looking at Everett.
So, Mr. Hannaford, this is the only one-time funding, $1.2 million, but when it's start, it become more active and actives and keep running, so we need more funding. It was actually, when the funding got approved, it was only for 400 patients, 400 Vermonters. But every clinic in Vermont, we have 7 methadone clinic, OTP clinics in Vermont. Each clinic is roughly around 350 to 400 patients. It's not going to work. For 1.2 million, it's going to go away within a year. So we need more funding for that. So that's the one solution. The second solution is you probably know that the opioid overdoses, what we see 100,000 people last year, 107,000 people. Most of the opioid, I'm addiction psychiatrist, what I see, the most of the people who die to opioid overdoses, they are not in treatment. 75%, or nearly roughly 70 to 75% people who die to opioid overdoses, they've never been in treatment, they've never received any treatment. What we are doing, we are pouring millions and millions of dollars on the rest of the 25% people. We are. And so that's why we're still seeing like hundreds and thousands of people dying every year. So what the solution towards like Wheels and Waves program, but mobile methadone clinic, especially in countryside like Vermont, rural areas where it's so difficult to reach out to people, you can, Senator would know that because it's every clinic in 7, we have 6 counties where we have 0 methadone clinic, no methadone clinic. 30 to 40 minutes drive to get to the methadone clinic. If someone who's my patient has 3 DUI, how do I expect him to come to clinic with DUI to get the methadone dose every day for 90 days? It's not practically possible. When we work with the patient, it's difficult. It's extraordinarily difficult. So we need to reach out to them. And the mobile methadone clinic is a viable option. It has been practiced. It has been done. It's very good results. So we should be doing that. So mobile methadone clinic could be, and I actually think beyond mobile methadone clinic in rural areas, the mobile methadone clinic, obviously it can be used for harm reduction purposes like Narcan, fentanyl testing strip, awareness of synthetic opioids. So that's going to be useful for that. The third one, which I think this was actually the more access to or establishing or more sober houses. That's a big piece in addiction psychiatry, addiction medicine, because we've been focusing for several decades on Suboxone, methadone, and Vivitrol. We've been doing this for a long time. The still deaths are not coming down. I think the biggest piece is recovery. We're not really focusing much on recovery, especially we are struggling. As a state of Vermont, we are struggling. We have no sober living. Folks are just come to the hospital, get detox, leave the hospital, go to the motel. That's their living. They go back to the shelters where there's no healthy living, no place to recover, no therapies, no job skill building, nothing. Like literally the something which we really need to establish. Sober houses should be there, or we should be spending more money on that, and they should be embedded with IOP and the treatment providers and counselors. That's critical. Now, sober housing not should be just they live there and do nothing. There has to be like programmed the way they should rehabilitate. And one thing obviously we see across the country, but I'm seeing in the state of Vermont, I worked in New York and Boston, but I did notice here, the folks who are coming from correction, they're struggling a lot. They're struggling in various ways. First, when they come to the clinic, they are handcuffed, they are chained, escorted by sheriff. That's really no dignity and respect for those. And they're sitting in a waiting area for 30 minutes to see a doctor. What do you expect from him? Will he come next time when he get to the methadone? It's so humiliating for them. It's so embarrassing. That's why most of patients don't want to come to not the Westridge, but any methadone clinic. It is strict. I think the mobile methadone clinic, what we've been talking about, is a solution. Why don't we just send the mobile methadone clinic to them at least once or twice a week and get the methadone there, or just give them the take home there. Take home, we call take home, but it's going to be take jail. So I think that could be a solution. And then I did notice somewhere in this bill that re-entry in Medicaid, that's a good thing. You know this is what I'm talking. So that's a good thing. Thanks for doing that. And also, when they leave the jail, I think we all know this, they are the higher risk of overdose because tolerance goes down, there's fentanyl sitting outside waiting for them. As soon as they hit the fentanyl, and they're done. So I think they should be at least, if they're not getting to the methadone clinic, they should be placed on Suboxone or at least Sublocade injection, which is good for a month. It's going to be a big preventive factor for them from this fentanyl crisis. It's going to be a game changer. We should be introducing sublicate injection to, especially to incarcerate. Rhode Island is amazing. They're doing an amazing job. I think we should adopt their model. They've been doing those things. We should be adopting their Rhode Island model for incarcerated people. It's amazing. It's very robust. The last thing, which is very important, again, it is something that we did for Suboxone. Ryan, the law that we waived during the COVID-19 for Suboxone through telehealth, but it's not for methadone. We need for methadone. I can give you hundreds of examples where people, first of all, we as a rural state, we do not have physicians. We have shortage of physicians. We expect people to come and see a physician in order to get methadone. That's not going to happen. Practically, it's difficult because we do not have so many physicians to sit there in the methadone clinic. They have to wait for weeks. They have to wait for weeks in order to see a physician or in order to come in person to get the methadone. Now, Dr. Davis discharged a patient today, and my clinic day is only on Wednesday, for example, or my clinic is only on Monday. This patient has to wait for 4 days for no reason. And because he's required to see a physician in order to get methadone. So it really doesn't make a whole lot of real sense. It's no offense to HHS or SAMHSA. It doesn't really make. I wrote a letter to editor.
You got to tell Congress that one. 'Cause
Okay,
they're the
so
ones that
the
write
Senate
law.
was going to. I wrote a letter to the editor about this issue when I was working in the VA for same reason that this should be waived because, and for no reason, the people when they get discharged from ED or hospital, they're being placed on Suboxone if they don't want to because they put them as a bridge. You're going to see a doctor in 4 or 5 days, so you just take the Suboxone for no reason. That's the biggest barrier. We should be at least doing in a way that if we have an on-site nurse and we can have some, every specialty is on telehealth now, infectious disease, endocrine, so methadone is really struggling. So I think those are the 5 obviously things. I mean, I'm not going to talk about psychiatry, which is I'm a psychiatrist too. There are several things, but I really appreciate your attention, and I would like to hear your thoughts once everybody's done.
Judy, you had him ready,
Thank you.
didn't you?
I did.
Thank
I did. Thank you.
Thank you so much.
Dr.
Thank you.
Chief Phil Cohen?
Thank you, Senator Welch and Secretary Becerra, for coming to Rutland to hear firsthand what the opioid crisis looks like here. I want to talk about briefly what the response has been in the city, and specifically with the police department. Going back to 2013, when Project Vision was created. It's a community coalition that was organized, as I said, in 2013, promoting collaboration to expand community engagement, build great neighborhoods, and improve public health. And it really was formed in recognition that we can't simply arrest our way out of this problem. And so that's the approach the city took then, and 10 years later, it's the same approach. What does that look like for the police department? The police department at the time provided an executive director of Project Vision, really to coordinate the efforts of all our agencies, non-governmental organizations within the community to help deal with the opioid crisis. It was a full-time position dedicated solely to that. And under that executive director, we established a community outreach team, which consisted of, and probably one of the first agencies in the state to have an embedded crisis clinician with the police department to respond to calls for service. Again, the idea was to produce better outcomes. Part of that community engagement team, we also have personnel assigned to the treatment court. We have a school resource officer. We have a crime and intelligence analyst. And all of those efforts are supported by our patrol and detective divisions at the police department. What we saw sort of early on was that with the opioid crisis, as Dr. Ahmed mentioned, Westridge, and we saw as treatment capacity increased, we saw a decrease in our cash-ready crimes. So many of the crimes being committed to support someone suffering from substance use disorder, we saw a decrease. So a lot of our property crimes, our larcenies, and shoplifting, all those sorts of things, we saw go down as treatment capacity increased. But our current trends are worrying. Again, we're 10 years into this since Project Vision was created. I think COVID negatively impacted the progress we made early on, and the numbers you can probably see in the in some of our charts, you'll see that. And as I said, it's worrying. The numbers are not flattering. So we've had some observations that you've heard from our medical professionals in the room. We've seen some of the same things. We've seen a rise in opiate overdoses in people who take non-opiate street drugs. We've also needed to use multiple doses of Narcan to reverse the effects a patient is experiencing. It's been incredibly difficult, as you, I think, rightfully pointed out, the difficulty we have in identifying qualified candidates to be police officers and deal with the issues facing the community. So what have we done to address those sorts of things? Last year, with the support of the mayor and the Board of Aldermen, we created a non-sworn position to respond to calls for service that are not criminal in nature. And again, the idea, and that position is called our Community Resource Specialist. And the idea is to connect those in the community with non-criminal matters or issues to connect with the appropriate resources in the community. And that particular position can spend more time, almost as a case manager, as I said, under the auspices of Project Vision and the executive director of our outreach team, to really spend time to connect with the appropriate resources and to have better outcomes. And I think the mayor was prudent in his response when I requested the position. I requested two, and he said, let's prove that it works first. So we approved one, and to his word, this fiscal year, he approved a second one. So we do have funding for a second position that we're looking to fill, because I think we are producing better outcomes. We're not looking to provide a police response to matters that don't require a police response. As you said, it's difficult for us to hire the officers. It is easier for us to hire a non-sworn officer. And as I said, and I think we're producing better outcomes. So we're looking to expand that in the next fiscal year. Some other things you heard from our medical professionals, again, it's somewhat anecdotal on our part, but we're dealing with many of the same community members, right? Those suffering from substance use disorder, unfortunately, are engaging in criminal activity to support their habit. And so this is anecdotal on our part, but I'm sure there's data that supports it. But what we're seeing is that those who do make it to residential treatment are coming out too soon. Again, not being the medical professionals, but that's what we're seeing. And so, unfortunately, there's funding, apparently in Vermont anyway, that supports 14 days. But we look at some of our bordering states, and it's 30 to 90 days. And I think we're seeing, as I said, anecdotally, we're seeing better outcomes from those who are going out of state and then coming back. And that's what we're looking for. I think the impact will not just be a benefit to public safety, but it really impacts the health of those we're trying to serve. And so that's what we're hoping for, that someone will take a hard look at going forward.
Thanks, Chief.
Yeah, sure.
Thank you. Turn over to the secretary.
Just a couple of quick reactions. First, Mayor, thank you for having the foresight to test. I mean, that's a good thing about executives, right? You don't have a choice but to make sure it works before you fund something. You got to make sure that you get something out of it. So I'm glad, Chief, that you all were able to show that you deserve to get a second person. We're doing something at HHS, totally different area, maternal health. There's still in America pockets where we have worse outcomes than in some developing countries when it comes to a woman surviving the delivery of her baby, or surviving for a year, or the baby surviving. So the president tasked us to do more to help women in America and their babies live to see the first year. And so we did something. We challenged every state through the Medicaid program, where right now under the Medicaid laws that Congress passed, we can provide up to 60 days of maternal postpartum care coverage to any woman after she's delivered. But unfortunately, what happens is 60 days goes by, and all of a sudden on the 61st day, you lose your coverage. And all of a sudden, that woman is on her own with that baby. And oftentimes you see lapse. Just as you were just saying, 14 days of coverage for someone who's trying to get off of a substance, not enough. We are now offering states, we're challenging them to accept 365 days of coverage for a woman postpartum. So for a full year, she will get coverage, and we at the federal level will cover most of the cost that a state has for its Medicaid program to cover that woman. There's some close to 1 million women in America who would qualify. About half of the states have taken us up on the challenge. I suspect Vermont has as well. But there's still half of the states that haven't. And there's some 500,000 or 600,000 women who are in that risk category who they or their baby may not be around within a year. We got to figure out how to do something so that we can incent what you just mentioned, Chief, which is getting more coverage for more people so you can get them through the process, because it does us no good to capture them for a moment and then put them back out in the community to commit the larceny, to get back and get high, and then ultimately possibly die. So we're looking for ways to work with you on that. And I wish I could say that we're going to fund every one of the 5 or 6 or 7 things that you pointed out, Doctor. We're not going to be able to. We do, as much as we've got more money now than we've ever had before, it's still not enough. But we're looking for the good projects. And this is where I say it with Senator Welch in front of me. We want to know what programs to seed with a little bit of money. Because just as, Chief, you proved to the mayor that your program was going to work and you needed 2 people, and he said, I'd give you funding for 1. I need to prove to Congress, because I have to go back to Congress and prove to Senator Welch that the money I spent, whether it was for fentanyl strips to make sure that somebody isn't getting high on something they think is cocaine and it really is laced with fentanyl, I got to prove to Congress that the money, the taxpayer money we're spending is going to work. And so we need a good program. And so we look for the programs that we call our demonstrations, our pilots. And then if they work, then you come back to me or the mayor or Congress, and then we can go bigger. But we need to prove it, because we need credible cases that are backed up by the evidence, because there's not enough money to go around everything, and we got to target the money to where we can make good use and come back and say we got a good story. So I just want to mention that. There are a lot of other things, but Senator, let me stop because I know others probably have comments.
Well, and you've got a schedule, but I do want to say this, that this has been an area of enormous bipartisan cooperation in Congress. Every community, it doesn't matter, red community, red state, blue state, suffers and has family members and loved ones who are suffering from addiction. And there has been, by and large, a very strong bipartisan effort in Congress to provide the resources to communities. The other thing I'll say is that my job is relatively easy, because it's about appropriating money to get those resources back to communities. I just want to express my gratitude to the frontline folks, and I know there's some frontline folks out there, because you have to deal with that person showing up at the emergency room, with that person's child, with the children, the other brothers and sisters, and that is hard. And believe me, the Secretary understands that, and I do, Bernie does, Becca Ballin does, and I know Patrick Leahy surely did. So my gratitude to the folks on the board and all of you who are day in and day out dealing with this. But you did mention that program of the access through the wheel, which was a earmarked that I was responsible for, and I think it's proven its worth. It really does work, and it's inexpensive, and telehealth has really proven its utility, and that is something that we advocated for, and I think you've proven how that does work, and Mr. Secretary will be in Congress advocating to get more opportunity to distribute the medication. Yeah. I want to open up to the press if they have any questions of the Secretary. He's on a tight schedule. He's got a plane, and even though he's a big shot, they don't keep it waiting for him. It's not his plane. He's got a schedule. He's got to go to Albany. So, Judy, maybe we could just have a little bit of opportunity if the press has any questions they have of Secretary Becerra or anyone. All right. If not, you can go ahead, Calvin.
One last question, Secretary. With the pandemic state of emergency expiring, there's a lot of waivers, a lot of money for Medicare that's tied to that. What will the expiration of that generally mean for healthcare for Vermonters, but also for some of these initiatives that we're talking about?
Yeah, I don't know how many Americans actually recognize that during this declaration of a public health emergency, and I have re-upped that declaration since the president took office. But once the emergency related to COVID does expire, and we will get there at some point, all those flexible authorities that we had, all those additional resources that Senator Welch and his colleagues made available really start to expire as well. Right, actually, the money pretty much has expired, but the authorities are still there. The telehealth opportunities that we have, those are principally because under the public health emergency, we were able to undo some of the constraints. Those kick right back in, although some of them, Senator Welch and his colleagues in both the Inflation Reduction Act, previous legislation, allowed us to extend them. But they're going to expire. And unless Congress gets together and reforms those telehealth laws, you're going to be constrained in using all the telehealth opportunities that have been so successful, especially in rural parts of the country. And so we hope that there will be bipartisan support for reforming some of those telehealth constraints that we have right now. That goes away. The ability to help providers in many ways that I suspect Ms. Fox can tell you about the protections that Rutland Regional had from liability in providing a lot of care, because during this period of emergency, we allowed healthcare providers, facilities to do things that otherwise might be really risky, but it was in the cause of saving lives. Those types of protections against liability expire as well, and it's going to be much tougher for a facility to want to take on those types of obligations, knowing that they're no longer protected against liability for trying to do good. And so there are a lot of things that are going to happen. We know that at some point the declaration, I will have to say, based on the scientists, that we're no longer in a state of emergency with regard to COVID, and we have to be ready. And probably the biggest one is Medicaid. There are some 12 to 15 million Americans who today have access to health care because they qualify for Medicaid while we were in this COVID real severe pandemic. They will now begin to lose it because the flexibilities that allowed us to keep them on Medicaid will go away. And so we're working with the states, including with Vermont, to try to make sure that as those flexibilities go away, we're not going to let just folks fall through the cracks.
Thank you. Judy, thank you very much. I want to thank Rutland Hospital, Regional Medical Center, thank all of the panelists for the tremendous work that you're doing. More work to be done. It never stops. Really, and you know what? We'll never stop.
Amen.
Right? It's Rutland strong. And Secretary Becerra, I'm so honored that on my first day of work, officially, you're here at my side with the folks from Rutland, and we are going to get these ideas back to you, and I'm going to be on your case, and they're going to be on my case, fighting to keep this good work going. Thank you all very much.
Thank you.
Thank you.